Welcome to KACF's Giving Summit virtual series, In the Front Line of COVID-19, Saving Lives. I'm Kyung Yoon, the president and co-founder of the Korean American Community Foundation. The coronavirus pandemic has created an unprecedented level of uncertainty in our lives, and yet we are also witnessing acts of incredible selflessness, solidarity, and generosity. Our Giving Summit is an opportunity to learn from each other and examine how all of us can contribute to making a difference in these challenging times. Last week, we had a conversation with two nonprofit leaders discussing the short and long-term impact of COVID-19 on the Korean American community. Today, we're pleased to host a conversation with medical professionals on the front line of the pandemic. The program will be moderated by none other than our own KACF board chair, Dr. Stephen Yang, professor of orthopedic surgery at NYU Langone Medical Center. Stephen?
Thank you, Kyung. Yeah, I'm really pleased to be moderating this conversation with some very esteemed medical colleagues who are on the front line of the COVID-19 pandemic. Today, we have Dr. Jung Ted Kim, professor and executive vice chairman of the Department of Anesthesiology, Perioperative Care, and Pain Medicine at NYU Langone Health. And we also have Dr. Hyunji Lee, the president of the Korean American Physicians Association of New York. And so, as all of you know, that since the first case of COVID positive patient was identified in the United States, we've been inundated daily by the grim numbers and statistics of the infected, the hospitalized, the ventilator dependent, and of course, the death counts. And this daily avalanche of information and disinformation has been difficult to distill and comprehend even by the most scientifically savvy. And we in New York live in the epicenter of this pandemic. And the very large Korean American community here is being disproportionately affected by it in many ways. And so it's so important that our community understands the nature of this healthcare crisis and have access to all the resources available to them. As always, the Korean American Community Foundation is here to support the most vulnerable in our population. You should know that this disease is hitting people of color the hardest. The two zip codes in the city with the highest rates of confirmed cases are in Queens, which is home to so many Korean Americans. And Asian Americans in the city represent an unusually high 23% of confirmed cases, although interestingly, they have the lowest death rates. So in the course of this medical crisis, healthcare workers have been called upon to respond in ways far beyond their calling. All specialties of medicine have stepped up to address the needs of this surge of patients. At my institution, like many other hospitals, dermatologists, radiologists, plastic surgeons, and even orthopedic surgeons like myself have been called upon to care for COVID patients, but some are on the front lines of this effort. So for a pulmonary disease like COVID, which often requires intubation and ventilator support, the management of a patient's airway is critical, and there's no one better acquainted with airway management than our hospital anesthesiologists, and they have been performing an essential role in this pandemic. And in the community, the farthest forward in the trenches are our primary care providers, who are often the first to identify the disease. They're the most trusted and true frontline caregivers. And those who serve the members of our community in this capacity are the ones who advocate best for access to healthcare resources for our sick. So we're very fortunate today to have two of these outstanding Korean American physicians on the front lines. Dr. Kim, let's start with you. It's really great to have you on the panel. Could you tell us what your role is in the hospital and how your team has been mobilized in this pandemic?
Thank you, Stephen. So as my role as a vice chairman of anesthesia at NYU Langone, one of the responsibilities is to allocate resources to four different hospitals throughout New York, as well as one affiliated hospital in Long Island. Early on, when we were watching the Italians and dealing with this crisis, we saw anesthesiologists in the front line, and we saw some of our equipment being used there. So we knew we'd have a fairly big role in this crisis. So when we saw our first few cases of COVID, we relieved our intensivists who happened to give anesthesia to the ICUs. We also later sent our transplant anesthesiologists over to the ICU to work as intensivists. We also created special airway teams, and these are the teams that go around and intubate those critically ill patients who need to be put on ventilators. As time progressed, we noticed our intensivists were spread out too thin. So one of the things we're good at is doing small procedures. So we are putting in the special IVs into the arteries and into the veins that help monitor and give drugs to these patients. Amazingly, one of the things that requires a lot of our resources is this thing called proning, which is positioning a patient in their stomach while they're ventilated to just rescue some of the lung tissue so that they can get oxygenated well. And this actually takes a lot of manpower. We've actually recruited orthopedic surgeons such as yourself to help us with this. At the height, we were down to probably less than 10% of our staff to man the operating rooms, because remember, there are still critically ill patients that need operations during this crisis. And we were very fortunate that we were still able to have a small contingent of anesthesiologists who can perform some of the critical operations that were needed during this crisis.
So Dr. Kim, I'd like to ask you what's probably on most people's minds, which is, if you could help us separate fact from fiction, basically like things like what are the symptoms of coronavirus, and when should you go to the ER? Should we be wearing masks? And what about the drugs hydroxychloroquine and azithromycin? There's so much controversy. And when is a patient deemed clear, especially if you had just mild symptoms and you haven't seen a doctor?
So a lot of science is going to come out in the near future, and there's a lot of anecdotal conversation about this, and I don't want to add to this discussion, and because we do have a primary care doctor who's going to tell us more about what the symptoms are. The symptoms that we're seeing, remember, we're seeing the most critical, catastrophic incidents. By the time you see an anesthesiologist, you're one of the very few people who have to get a ventilator, and you don't. I would say the vast majority of people are going to be taken care of at home. I can only tell you anecdotal stories from my own staff, because many of my own staff have contracted COVID. Many of them are back and working currently. And the symptoms have varied from being a little tired to the trifecta of fever, cough, and extreme muscle ache. And I'd have to say most of them complain about the muscle ache as the most painful part of the procedure. So I would say I think we have to wait for the science. Plaquenil, some of the antiviral agents, we're going to find out not only are they effective, but when to use them. The problem is we don't know when these drugs are the most effective. So a drug that may not seem to be working, it may be because you didn't give it at the right time. So we're going to find a lot about the science later.
Yeah, it's interesting. I mean, I think there's so very little data on the use of these drugs, but in my very short time on the COVID wards, I noticed that here at NYU, it seems like every patient who's COVID positive is being treated with azithromycin and Plaquenil. Interesting. But I also wanted to ask you about the current situation here in the hospital. I mean, you get to see the whole length and breadth of the hospital. You have a great perspective on this. Could you give our listeners a sense of the current situation in the hospitals? I mean, do we have enough ICU beds, enough ventilators? And there even seem to be some indicators, at least in our institution and maybe more broadly, that the pandemic may be cresting, here at the hospital and also citywide. Do you think this is real?
So I go back to in the beginning. There was so much anxiety in the hospital that we wouldn't be able to keep pace with this crisis. Our biggest fear was that we were going to run out of ventilators. We even had plans and designs on how to split ventilators so that one ventilator could be used for multiple patients. What happened about a week ago is we noticed there was a plateau. And then we noticed that the number of patients that were on ventilators were dropping. Remember, a big hospital like NYU typically has 30 to 40 ventilated patients prior to COVID. We went to over 180, and this is a huge amount of resources. And when we started dipping and going under 170 and heading towards 160, there was a huge sigh of relief. The whole thought of rationing care, deciding who gets care and who doesn't, is very anxiety provoking. And just the fact that we have enough ventilators, we have the capacity, we have the ICU bed, it just creates such a sense of relief. The gloom is starting to dissipate, and we do have ventilators now. We do have capacity in the ICU, and there appears to be a flattening or a slight decrease in the number of ventilated patients.
So, none of us here at the hospital, and I'm sure this is the same at hospitals around the city and probably around the country. None of us are really doing what we normally do. From my perspective, and for many of the specialists, none of us are doing our usual elective surgical cases. Even the outpatient centers are not seeing the usual spectrum of patients that they see. Everything has been reallocated. All our resources have been devoted to treating the coronavirus patients simply because there's so many of them in this surge. We see on the news all the time of healthcare workers, our nurses, our MPs, our PAs, all struggling. What's your sense of how the healthcare professionals are doing in general, both at NYU and elsewhere?
So I think I'm extremely proud of the people that I've been working with. They come in the beginning, they were all extremely frightened. If you ask most of them, their number one concern was passing on COVID to their family members or their children. And in fact, many people in our departments have sent their children away, so they've been working without their families to support them. Despite being frightened, despite knowing all the risks, and particularly in anesthesia, we do the intubations, and this is called a super spreader event, which means we're actually aerosolizing the virus while we're doing this procedure, and everyone is being exposed to the virus during this procedure. Despite all the dangers, these people come to work every day. And this is just a story, anecdotal story about anesthesiologists. There are anecdotal stories about everybody in the hospital doing amazing things. And despite all the fears and risks, they still come to work. They are the heroes. I mean, I, as an administrator, I don't consider myself the heroes. I'm just making plans. But these people are phenomenal. And coming to work every day, knowing that you have these risks, I'm so proud to be around these people.
Yeah, Ted, I have to say you're much too modest. I mean, your leadership has been so important in the success of this institution in handling the pandemic, and I think people like you and certainly frontline workers like those in the emergency room, in the ICUs, and elsewhere on the floors that are treating COVID patients. I mean, they're really doing an extraordinary job, and I have to say that. I think we have a lot to be proud of in our profession for the way in which we've conducted ourselves under these very extraordinary circumstances. I want to turn the conversation to Dr. Lee. Dr. Hyunji Lee works, very closely with the Korean American community as a primary care provider. Dr. Lee, I was wondering if you could tell us a little bit about what you were seeing and what you were hearing at the onset of the COVID pandemic here in New York.
Hi. So what basically with all this pandemic, I think our Korean community has been pretty good actually. General admission rate in ICU is actually lower in comparison to other minority groups, and we are at the heart of Queens, Elmhurst, and Bergen, where huge number of COVID patients have been confirmed. But the Korean community actually was keeping a very close eye on what the situation that was unfolding in Korea, South Korea. So as the epidemic was spreading in South Korea, our community was very in tune with what was going on over there, because the holiday, it was December, so a lot of people were traveling to South Korea, and they were so very aware. And a lot of our 유학생s, students, who also went back home, and there was a time of during January is when they were more concerned. So they actually started some sort of wearing masks, social distancing, mitigation process. So they actually took a step ahead before that pandemic hit in New York City. And they started, sort of, canceling all large group events. They canceled the lunar parade. They canceled March 1st, the big gathering for Koreans in Flushing. They have a 3일 운동. So it's like a celebration of the independence from Japan. So a lot of these big gatherings were already being, canceled. They started mitigation, and they also, like churches, became very aware of the situation because that big church in Daegu was the epicenter in South Korea. So they were following that. So even churches at the time was recommending wearing masks for their services. So and I think that was very smart of our community. And one of the biggest anxiety in our Korean community was that, oh, please don't let one of the Koreans be the first patient to be, diagnosed in New York. Then we'd be in big trouble because we were very much afraid. And I felt this anxiety in my patients too. Very much afraid that if the first patient was a Korean, it would be a huge negative impact on our Korean community. So in January, I was seeing a lot of flu patients. So a lot of my patients were afraid, is this COVID already? But most of them were testing positive for flu. So it was a lot of reassuring. Oh, you just have the flu. It's flu A, flu B, don't worry. But they were already in the background, the anxiety. And our community was already, using hand sanitizers, watching for the symptoms, and watching closely what was happening in New York. And when that first New York patient came, on the media, it was a huge sigh of relief. Oh, okay, now we could have the COVID and we're okay. Our community will be safe. So, so that was the general feel that was happening in our community.
Yeah. So Dr. Lee, you're president of the Korean American
Yeah,
Physicians Association of New York, which is an affinity group for Korean American doctors.
yeah.
And most significantly, it started the COVID-19 hotline. Can you tell us a little bit about that and what spurred that initiative?
Right. So we were also observing what was happening in South Korea, especially because our patients were anxious and they were asking about it. So as we were watching, and I was watching, there was two ways this can go. Either we can become like South Korea, or it was going to be like Italy. So as we were watching this, the media, our mayors, our governors are saying, "Oh, it's not a matter of if, but it's when." So, watching that and the anxiety level, we decided we need to do something in order to sort of, calm down our community and be a little bit step ahead if it does hit, that we would be prepared to help our community. And there are 311 hotline, but I knew personally from using 311 is very hard to get through somebody, or even for regular things. So when the pandemic comes, we knew that it was going to be very difficult for our community to get through. And then second of all, the language barrier, it would be very difficult to get information in Korean. So there were other hotlines in the Korean community, like from Hanine, they made an app, but we wanted to make it specific for the COVID medical issues. So we scrambled to put this together, and it really helped out. I think it was one of the smart things that we did.
Yeah, Dr. Lee, I think it's incredibly admirable that the physicians organization were able to put together this hotline. Can you tell me some of the challenges that you confronted in putting together this hotline, and who are the people that a caller might be likely to speak with, and what sort of services could be provided through the hotline?
Well, the challenges was actually convincing people in the beginning because it was right before the pandemic hit, the first case. So it was very challenging to convince them this is something we need. It's coming, and we gotta be prepared. And our community is gonna need somewhere to get information and have some sort of medical advice coming. And so that was a huge challenge. And then the secondary was money, of course, trying to find funds. And thank you for KACF for helping, but trying to find the funds to support the hotline. And once that was done, we just scrambled. And regardless of where the funds were, we got to do this. So we did that, and it sure enough, it was just a very needed thing because in the beginning we were getting up to 150 calls, and we had I specified, I tried to get our physicians to actually take the calls because we knew that a lot of these calls would be clinically related. And we were correct on that judgment because a lot of the calls that came in were patients who were starting to develop symptoms, but they weren't sure whether they can go to the hospital or where to go because a lot of the medical facilities were now afraid, and they were not necessarily encouraging them to come into the office for the possibility that they would have COVID. And the testing was not readily available to us. As you know, they tried to put out the testing kits in late January, but CDC had to recall a lot of these test kits. So readily, the test kits were not available. And then secondly, even if you were really sick and you were in the ER trying to get tested, the physicians had to really call CDC, convince them that the testing was needed, and then get authorization from CDC to actually do the testing. So initially, the testing was not readily available. And from what we were observing from South Korea data that was coming out, that 80% was not as sick. So we were able to use the hotline to calm down the community, let them know these symptoms, mild symptoms, fever, dry cough. You can have some muscle aches, but it will be okay. Take Tylenol, try to treat yourself like as if it's something like a bad flu. So, and then we try to give them a criteria when they can go to the hospital. If you have short of breath, if you start getting short of breath, and that the fevers are getting high, not coming down, and we gave specific directions when they can go to the ER. I mean, having said this, a lot of the calls were also like from organizations themselves, nonprofit. They called to ask us for advice. How can we tell, or how can we advise our organizations like family center? There were many different organizations that called us as well for directions. And then the number three, we were getting calls from all over the state suddenly. We had calls coming from Tennessee, Indiana, Texas, Georgia, and suddenly it became more like a whole entire state hotline.
Yeah, Dr. Lee, are you able to share for the benefit of our listeners uh, how they can get through to the hotline? Are we able to do this?
Yes, you can just call the number. And there are about 20, we created up to 25 lines just in case. And we had our doctors just sign on when they can, and the call rotates. But because the volume was so high that we were missing calls, so we tried to encourage through our media, radio, newspaper to just try calling, and eventually one of us will pick up. Eventually, we had to actually enlist some nurses and medical students, but we give specific directions, a script, and what to do, how to answer some of the questions. But majority of the questions that were coming in were from our community who was concerned about their symptoms and whether they needed to go to the emergency room or the hospital or not. And many times we were able to give them some voice of calming and reassurance that they'll be okay. And a lot of the symptoms were actually in a mild cases, and we were glad to provide this service.
Yes. So, Dr. Lee, language access is so critical to make sure that immigrant communities, like the Korean American community, have access to quality healthcare in a language they understand. And overall, we've seen how COVID-19 is disproportionately affecting low-income people of color. And I was
Right.
wondering if you have any thoughts on these health inequities, and especially with Korean Americans who have such high rates of being uninsured.
Right. So access is a big issue, I guess. A lot of the calls that also came in was concerned that they wouldn't be able to pay for the hospitalization, or and they wouldn't be able to pay for the treatments. And they were very aware of what the cost was going to be if they were to actually get admitted, get intubated. So a lot of our minority community, number one, access. They have poor access to healthcare because of insurance issues. Number two, because they have poor access regularly with the primary care doctor, most of them do not have primary care doctor. So they have comorbidity, meaning high blood pressure, diabetes. Like in African American community, there's a high number of asthmatics. So a lot of these comorbidity did play into the whole scene that we're seeing right now. And they probably did play into, unfortunately, high more mortality morbidity rate in the minority community.
Yeah, the situation with the coronavirus pandemic seems to be changing almost on a daily basis, and we've been focusing on the here and now. But what do you think is the long-term impact of COVID-19 for people and for those who work in healthcare? What are your thoughts on this, Dr. Kim?
So it's interesting that you bring this up because as the capacity in the hospital increases and as we have more resources, we're holding meetings on how to take care of patients who don't have COVID. There is a lot of collateral damage going on because there are patients who have other conditions besides COVID that are getting hurt during this crisis. We're a big cancer transplant and cardiovascular hospital, as well as orthopedics. But these patients aren't getting, their care has been delayed. And it's very difficult to tell a lady with breast cancer that their operation has to be delayed 3 weeks until we get this crisis over with. So as the capacity increases, as there's a softening of the self-quarantine, our plan is to try to create an environment where we can take care of these patients. We're always going to have to allocate resources to COVID, but we also have to take care of patients who don't have COVID. And time will tell what the effects of COVID has had on patients who have life-threatening diseases that have nothing to do with COVID. And so we're going to find this out in the next coming year.
Yeah, I think that's exactly right. So I have a note here that I want to ask the same question of Dr. Lee, but I have a note here that we're going to be taking questions from all of you who are listening in, and so please open your chat box and click on Q&A in the drop box, and we're going to be taking your questions. So, please write them in right now. So, Dr. Lee, I want to turn to you while our listeners are putting in their question and answers, and I want to ask you sort of the same question, which is, what's the long-term impact, in your opinion, of COVID-19 for people and for those in healthcare? What are your thoughts on that, Dr. Lee?
Well, interesting thing is, where did all of the other patients go is the question. A lot of times right now in the community, all we see now is COVID patients. So your typical hypertension, diabetes, where did our patients go? UTIs, where did they go? So interestingly enough, though, as the COVID was coming down, the hotline, it also became a question for other patients with other issues. Oh, and so we started having to answer questions, and then we were, oh, can you contact your primary care doctor? And a lot of times they were unable to reach their primary care doctor for whatever situation. The doctors may be deployed to the hospitals, or they had to close their clinic for whatever reasons. So our hotline also became, they started asking regular medical questions aside from COVID. But in terms of the healthcare, I think there were a lot of issues with our colleagues that some of them were getting infected, actually. And one of our colleagues actually also had a pneumonia, and we're getting to a place where a lot of our frontline workers, our frontline physicians, nurses now have developed the COVID, and they had some unfortunate deaths in our colleagues. So that kind of, as much as we were fighting, we were actually losing some of our colleagues to the virus, and that was kind of I mean, it's kind of expected, but when you hear it, it just hits you. So going forward, probably our also medical system, everything else, I think will, and it also comes down to insurance and accessibility and cost too, where the government will sort of come up with a solution to help rest of our community to get access and some kind of care in this environment. Mm.
Yeah, I think that's exactly right. So I want to, first of all, thank both of you for all these comments, but I'm going to pause here for a minute because I do want to turn to some of the questions that we're getting from our listeners. And I'm going to go to the first question here, which I guess both of you could potentially answer. The question is, may I ask if Gilead has allowed patients to be granted the use of remdesivir at your institutions? And if so, what was the success of using remdesivir for COVID-19? That's interesting because it's just been in the news about how there have been some positive results with the use of remdesivir in some of the more acutely ill COVID patients. Dr. Kim, do you want to tackle this at all?
Again, I mean, these are difficult questions to ask without having all the science and the statisticians. I mean, we're going to have a lot of anecdotal stories, but I think we're going to have some of that data is coming out soon. So that there are a lot of studies going on. So I'd rather wait and see the actual studies before we make a call.
Yeah, I agree. That's a tough question and a very very current one. To my knowledge, and I could be wrong here, but I don't believe remdesivir is being used widely at NYU Langone. I think these are being used experimentally, and I think Gilead has been granted compassionate use approval by the FDA, but I don't know much about it. Dr. Lee, have you been following this at all about the remdesivir?
Yes, because our colleagues we also create a different chat room when this was about to hit. We created a task force to sort of share information among the physician community to get a sense of what we're going to try and what's working, and basically share information throughout the hospital, New York City hospital system. And I think certain hospitals were given certain permission to do certain trials. So not everybody was on board to using all the same medicine. So one hospital was focused more on the hydroxychloroquine and azithromycin regimen. The other hospital, like remdesivir, and other hospital, they're trying out the antibody serum from the post-infective recover patients. So there are a lot of different trials going on. So right now, to say what works and what not works, there's no definitive science and data to say, okay, this works, and if it does, then we all use that medication. So I think we're a little bit still in the early stage of collecting data. So it's and I do hear a lot of positives, but right now we're still waiting for that final data to support whether this works or not. And
Yeah, I think,
once it works, we have that data, everybody's going to jump on it.
yeah, I think that's right. I have to agree with both of you. I mean, I think that none of us really know for sure if any of these drugs work with any level of certainty. None of these drugs have been subject to the kind of scrutiny that the FDA normally requires of drugs. There's been a lot of politicization of some of these drugs, and in particular the hydrochloroquine. Because I guess partly because we really don't have much else to use. But I would like to point out, because I know that there are people in the community who are taking drugs like Plaquenil, which is hydroxychloroquine, just simply because they feel like it might protect them, or that it may be treating the mild symptoms that they have, that they're not that are not requiring hospitalization. But these drugs have potential side effects, and I will say that the patients that I was caring for in the wards, the patients who were on Plaquenil were getting EKGs on a daily basis to check on their QT intervals, because there's a notable cardiac effect with these drugs. So I think people who are listening should be very aware of that. It's not something that you want to take without thought, because there are some significant potential adverse effects that can happen. So please be careful. I'm going to go to the next question here. The question is, as a school nurse, I'm concerned about antibodies, their efficacy. Just lost that there. There it is. I'm concerned about antibodies, their efficacy and possibility of additional COVID-19 infections and helping students and other staffers stay safe. I think maybe what the question is about is the accuracy of testing and the possibility of reinfection maybe. Yeah, Dr. Lee, do you want to tackle that one?
Well, having the antibody test, what we're looking for is whether you had a past infection, meaning that somehow you were infected, but you were one of those 80% that didn't have, mild symptoms, and some people didn't have symptoms at all. So if that's 50%, they said that. So if you were infected, you would have the antibodies. So then, are you immune after that? So that's what the test is getting at. That if you have antibody, then technically you're immune, meaning that you won't be able to get infected, and therefore you can go about your regular business, not having to worry about getting sick from the COVID virus. So and then of course there's a IgM test as well that gives you whether you're infected initially. But the concern is that even with IgG, when they were doing tests that post infection, that these patients have recovered, they tested them because they went back to give their antibodies. And what happened was some of them were still having viral load. So even without symptoms, so now these patients were also having a virus as well. So there was a sheddability, meaning that they were able to spread the virus even though they had no symptoms. So that's when these concerns came. And that's why there's that, is it so accurate? If you can still test positive for antibodies, then you think, oh, you're done, you're protected, you're immune. But if you still have that, that's why they said that you need to do both. You still have to do PCR to make sure you have whether you cleared of the virus itself, or you still have the virus on you, and that you're still spreading, you can still spread even with the antibodies, with IgG.
Yeah, Dr. Kim, do you have anything to add to that?
So there's a lot of controversy about the antibodies, but in the past, if you go with history, people tend to have some sort of immunity after these infections. I mean, we can go with all these anecdotal stories. There are certain populations of people, even when they get vaccines, that don't mount a good immunity. So, there's a lot of opinions on this. If you go historically, people do have some sort of immunity after resolving from an infection. And there are always some people who can't mount a proper antibody response to even vaccines. So, again, we have to wait for the science behind this. But, historically, there has been some immunity after resolving from one of these incidents.
So the next question here is there anything hospitals and healthcare workers need that can be provided by lay people like us, such as masks, food delivery, and PPE, personal protective equipment? Dr. Kim, do you have a response for this question?
So I've gained a lot of weight because a lot of food has been delivered, and I'm very grateful for all the food that we've gotten. In the beginning, there was a concern about getting protective masks and gowns. NYU's done a very good job of getting us our resources. It seems like it's always just in time. So you never know what can happen, what's going to happen next. A lot of our equipment is coming from outside the U.S. So we're very appreciative of the masks and the equipment that we've gotten from other people. So I think our people would rather have equipment. The food is great, but we're getting a little we've gotten a lot of that.
Yeah, I have to say, I was telling my wife Kathy that that the one thing about doing these 12-hour shifts on the COVID floors is that there's an abundance of food, breakfast, lunch, and dinner, and all of us who are working so hard found that none of us were lacking for food, and in fact, this potential for gaining weight, we're jokingly calling it the COVID-15, like the freshman 15 in college. So yeah, there's been no shortage of food, but it's been so wonderful to have, and all of us are very grateful for for the generosity of people in our community who are giving. My sense is at our institution, as well as many of the other hospitals in the area, that they are starting to level out on their supplies like masks, and I think the shortages are being addressed now. I happen to know that a very large men's clothing manufacturer had converted all their factories recently to producing masks, and the offer of those masks at our institution was actually declined because our supplies were adequate. So I think we're doing okay. I think some of the other hospitals may still be in need. I think some of the Health and Hospitals Corporation hospitals may be having more trouble in their supply chains. But yeah, I think everybody's contributions have been so gratefully welcome.
So Stephen, that's an excellent point, because just because we have enough equipment doesn't mean others do, and we always have to be considerate of the other hospitals in other areas.
Absolutely, I think that's exactly right. The next question is about South Korea, and it says the question is: South Korea has handled COVID-19 so effectively. Is there anything we can apply from their learnings or methods here in the U.S.? Dr. Lee, do you want to tackle that question?
Yes. Well, South Korea was already ready. They had experience with MERS epidemic. And so they already had a playbook in place. So, and also because of the pollution in Korea, they were already habitually wearing masks. So they think that's what helped them to sort of mitigate. And because they already had the playbook, the country knew what to do when there was like spots of cases and then clusters forming. So in terms of what we can learn from South Korea, I think it took a little time of convincing, but we started. Now we're wearing masks. You're not stigmatized for wearing masks. And now even our mayor mandated and our governor mandated wearing of masks, hand sanitizing, social distancing, all the mitigation. So we are now following what South Korea was doing. But the thing that we haven't done that South Korea is doing is testing. They're just aggressively massive testing. And not just that, they're contact tracing very aggressively, and they even have apps to alert people for anybody who's positive. So all of these measures are in place, which is very aggressive, proactive way of handling the situation. Right now in New York City and US, I feel like it's a little bit a step behind. So what we can take from Korea, we already started. Example, like I said, mask wearing. But I think for now, we have to follow that step into mass testing, aggressive testing, not just testing people who are very sick. Because right now, our target was just very sick patients. So the government probably need to roll out a lot more test kits and make it readily available for all of the private primary care doctors out in the community to help with this mass testing, tracing, and this is not something that we can just do ourselves as a medical organization and institution. Our government has to step in. Our Department of Health has to create these guide and playbook to reach out to our communities, mass test, so people know and be able to do what they're doing right now. And I think New York has done a fabulous job mitigating, following the instructions, social distancing. So we need to just step up this one more level, what Korea is doing, and aggressively do what we can to sort of continue the fight in this COVID.
Yeah, I think that's exactly right. We have a ton of questions here, and I'm thanking both of you in advance for fielding these questions. But I'm gonna keep going here. The next question is: I understand that there's a lot of bureaucratic blockers for getting a vaccine into production, including successful clinical trials and FDA approvals. Do you have any visibility into where the U.S. or the world is at this point in finding a vaccine for COVID? What stage of the process are we at? Dr. Kim, do you want to tackle this?
So I actually, as an anesthesiologist, this is really out of the realm of my field. In fact, I've just looked at the chat Zoom, and I know that there's some experts from Emory University listening to this who are actually in that field. So I don't want to embarrass myself and pretend to know something I don't know, especially since they're going to make fun of me later. But this is, like I said, this is out of my field of expertise.
Yeah, I have to say, outside of my expertise, in fact, I only know what I read in the newspapers, but I do know that I think about maybe a dozen or more companies that are in the process of producing a vaccine. Pfizer's, SmithKline, Inovio, I think Johnson and Johnson, Novavax, Sanofi. I think there are a whole bunch of
Yeah.
companies are involved.
Right. Bill Gates Foundation too.
That
Bill Gates Foundation
Bill
too.
Gates Foundation, yeah, yeah.
So,
Inovio is one of those companies, and in fact, the CEO of Inovio is a Korean American man who's an acquaintance of mine. I happened to have a conversation with him, and he mentioned that for them, the clinical trials are likely to start in the fall, which seems kind of late to me. Although I had heard that other companies may have clinical trials underway already. But I think there's quite a bit of time before we're going to have a vaccine. I'm going to move on to the next question here, which is it too early to begin thinking about what lessons we have learned and can implement, how we can be better prepared to help the Korean American community for the next time? Good question. Dr. Lee, do you want to respond to this?
well, next time, it's not too early to start thinking about the next time because we are already considering there may be a second wave in the fall. In our first wave, we did what we could. We scrambled. We weren't sure. Hopefully, by the second wave, and we're already preparing, that we will be better prepared. We can continue our hotline. We have actually a website that we created for all of our patients, our community to see. And somehow this website became more national, and they're actually using the website from Korea too. Believe it or not, interesting. But and also, I think in general, the public knows now what to do. So it's not like we have to teach them, oh, you got to do this, you got to wear masks. We are already aware. So next second wave, I think it's more important how we sort of create a system of testing and then getting this information to our community, and then for them to isolate, contact tracing, all of that we haven't been able to do. Now that we know something about the virus, and now that we have tried muddled through our first wave, for the second wave in the fall, we may be able to better kind of create a playbook to go through the steps, how we're going to test, isolate, and then contact trace, and sort of try to mitigate as much as possible. In the meantime, open up the society so that people can go about their business. And hopefully, the vaccine will come out, but I doubt vaccine will be available by the second wave. Probably next year, like 18 months, a third wave would probably most likely when the vaccine will be ready. And that's because it's just, you cannot rush it. You gotta go through the efficacy and safety, and animal trials first and then human trials. So there are a lot of steps to make sure that a vaccine is effective, but it has to be safe. So there's certain things you just cannot speed up, like, baking a cake. You cannot speed up. It is what it is, and it has to bake. It has to get through that time to be done. So as much as people are anxious to have that vaccine, it will take a little time. Meantime, we know what to do. We know how to, social distance, mitigate. We've already done this the first time around. Second time around, I think we'll be more effective and isolate cases better so that our community may be able to function at a certain level without having to shut down the entire city.
Yeah.
Does that answer your question?
Yeah, I think that's exactly right. I just want to say right now to all our listeners, our viewers, there's so many questions here. I apologize. I don't think we're going to be able to get to them all, but I'm going to run through just a few more. The next question is, how do you think quarantine lifting will work? Has South Korea lifted social isolations? Dr. Lee, are you aware of what the situation is in South Korea?
South Korea, I think they haven't quite put in a quarantine. That's why it's a success story. Not only were they able to flatten the curve around 10,000 per case, but they were able to like reduce mortality, meaning like death rate, if you see it, it's very low compared to US and Italy and other European countries. So they didn't quite put in a quarantine as we have done in New York or Wuhan, China. The contact tracing, isolating that initial group where that whole super spreader occurred. Patient 31 at a church member, huge church. It was like a more cultic church, but there were so many members, and that's where the explosion occurred in Daegu. So Korea was very aggressive in isolating these patients. They were tracing them, and they were making sure they stay home. They had all these apps. I mean, they lost a little bit of their freedom, but these apps kind of helped to sort of, and the Korean citizens were very self-conscious, so they really followed the government's instructions and to do that. So, and mask wearing was readily already in practice. It was very habitual already. It's not something new that we have to sort of encourage like in New York. So they were already doing that and social distancing as much as possible. So Korea didn't quite shut down like we did. And they didn't have to reopen, think through a reopening scenario like we have to do now in New York City.
Yeah, I think it's still unclear
Mm-hmm.
how this is all gonna pan out here in this
Right.
country.
Mm-hmm.
I mean, there's obviously been a bit of a back and forth about who will be dictating the lifting of the stay-at-home orders. The president has had at one point said that he would be in charge of when that would take place, and then of course our governors around the
Right.
country are now sort of taking
Right.
charge with
And
that.
I think that's when the antibody testing they keep talking about, because if you have some sort of immunity, maybe it's safe for that person now to go back into society and can go back to work. So
Yeah,
that's where that whole antibody testing talk has come about,
yeah,
evolved, and maybe it might work.
yeah. I think in New York originally, Governor Cuomo had
Yes.
placed the stay-at-home order to expire on April 29th, but just yesterday it was extended to May 15th.
Mm-hmm.
But I know everybody's trying to plan for how things will get back up and running. I know at the hospital here, there's been discussions about at what point and how we're going to be able to start functioning in a somewhat normal way. We're talking about testing all the doctors,
Mm-hmm.
testing patients before they come for surgery or presenting to the hospital as inpatients. But I think a lot remains to be seen. Dr. Kim, do you have a view on the lifting of social distancing, the quarantine, and stay-at-home orders?
So I think it's been very effective in New York. Our numbers in our hospital have been improving, and I think there's an awareness amongst the citizens of New York, to do their share. I mean, they're not protesting wearing a mask. They're not protesting this. They understand how serious this is. I've got to believe that, when the quarantine is lifted, there will be some form of social distancing out there. As for us, we will be, most likely, many of us will get tested. Um, uh, when the antibody comes out, there's a very good chance we'll all get some form of a test. And we'll have to see what we can do in terms of capacity, in terms of testing our patients. It would be nice to, for now, since we don't have a lot of patients coming to the operating room, it's easier to test everybody. But as caseloads grow, we're hoping that our capacity grows in terms of testing, and that would be ideal. But it all has to come down to resources and the number of patients we take care of. But I've got to believe that, New Yorkers have become very sensitive to this, and they are behaving quite well.
Yeah, I think that's right. So I'm afraid that our time is actually run out, and I want to thank everybody for joining us. And in particular, I want to thank Dr. Hyunji Lee and Dr. Jung-Ted Kim for joining us and providing us their very important perspectives on this COVID-19 pandemic. Thank you very much. And I also want to thank all the men and women in the front lines of the COVID-19 pandemic. So all of us are grappling with the intensifying and unprecedented impact of the COVID-19 pandemic, but this health and economic crisis has hit vulnerable, low-income families particularly hard. Through the KACF COVID-19 Community Action Fund, launched 2 weeks ago, we're supporting 7 organizations that are providing critical services to help Korean and Asian immigrant families, including the COVID-19 hotline that we've just been talking about. We're receiving many more requests and want to issue a second round of grants in the coming weeks. We hope that all of you will consider supporting the COVID-19 Community Action Fund. Thank you so much for tuning in today.